So echo also can guide us in diagnosing arrhythmias. Now this is like if you put your the pulse Doppler or the MO or the tissue Doppler on the atrial wall or on the intra-atrial septum, you may be able to make out these flutter waves, the opening of the AV valve, the episode. This is a case of atrial flutter where you can, with carotid sinus massage, you can see that the flutter is causing the mitral valve to open periodically. So here is a case of atrial fibrillation. You can see the intra-atrial septum. If you put the M-mode on the intra-atrial septum, it is fibrillating, and also the cardiac output is changing beat to beat in the lower thing, and you can see an absence of A wave. So this tells us there is an atrial fibrillation. Sometimes these things might be helpful. Junctional tachycardia, again, we do not see. You see a bradycardia is there. There is only an E wave. There is no A wave. So that also, this is not a junctional rhythm, sorry, it's not a tachycardia, it's a junctional rhythm. So adenosine can be both therapeutic as well as diagnostic. Some arrhythmias like atrial tachycardia or atrial flutter will slow down once you give an adenosine. So then you can unmask those flutter waves. Some tachycardias like AVNRT, AVRT can terminate. If they terminate with a P or a QRS, they are diagnostic of AVRT or AVNRT. And if it terminates with a QRS, it is diagnostic of a ectopic atrial tachycardia. So adenosine can be quite useful because it is both a therapeutic agent, and sometimes it will help you to dig out those flutter waves or P waves, and you can also see from what focus they are coming. So 6 milligram IV of adenosine, we do no harm. It's a short reversible agent, and it can be quite useful in unmasking the P waves as well as in therapeutics. The white QRS tachycardia, again another subject. The most common and most dreaded white QRS tachycardia is the ventricular tachycardia, which is associated with hemodynamic compromise sometimes or mostly. SVT with aberrancy and SVT with a pre-excitation. Pacemaker mediated tachycardias, drug effects, hyperkalemia. Again differentiated into regular, we have white complex tachycardia, that is VT or antidromic tachycardia or aberrancy. And the irregular is polymorphic VT, AF with pre-excitation. So this is a classification. So we would be better off if we take a short history, because history of ischemic heart disease or congestive heart failure would hint towards a possibility of ventricular tachycardia. The Canon A waves, the varying loudness of heart sound would again give us clues about ventricular tachycardia because of the AV dissociation these things happen. We can also give a carotid sinus massage, adenosine, to unmask the P waves, because adenosine will slow down the AV node. We can unmask the P waves and then differentiate the SVT from VT. Now, why it is important is this always seems to be a problem. We see a white QRS tachycardia, naturally the implication of a VT is much more severe. We would want to act fast, but then if it keeps happening again and again, you would be anxious to know whether you are over treating the arrhythmia also. So at some point of time, we need to take a call whether what we are dealing with. So it's important to have some clues. So generally VT would involve a wider QRS, a more bizarre ventricular activation. There are exceptions, but mostly we have to understand that it involves a more bizarre ventricular activation. That is one of the cardinal points of VT. More commonly associated with hemodynamic compromise, more commonly associated with the history of ischemic heart disease. That is your first go-to thing. Now the QRS will give us some clues. One is a Brugada sign. That is the activation from the R wave to the nadir of S wave. If it is more than 100, that suggests a VT. And Josephson sign, a small slurred notching in the nadir of S wave is also a feature of VT. Now, if you have these morphologies, the left bundle and the right bundle. So we will not worry too much about it. What I want to just emphasize is look at the initial activation. The initial activation, if it is sharp, if it is a small R wave that in a left bundle morphology, or a small R wave in a right bundle morphology, if it is sharp and having a shorter duration, it is more suggestive of a SVT. That is, the initial activation is passing through the His-Purkinje system. That's why it is more narrower. Narrower means more faster conduction, whereas more wider means it is more muscle to muscle conduction. So all these algorithms are actually based upon this principle only. So just to summarize how we approach VT, first thing is AV dissociation. You have features of AV dissociation because the atrial rates would be separate from the ventricular rates. If you see P waves in a rhythmic strip, so you are more convinced that it is a AV dissociation unless there is a VA conduction. Then like the morphology, I said monophasic R in with RBBB morphology or initial slurring or a QR or RR all suggest a VT. Whereas in the LBBB morphology, the R to the onset, there's a notch downstroke is there, initial activation is wide, a Q waves. So all these would suggest a VT. Concordance. Concordance also tells us that most of the almost all activation is happening through the ectopic focus. So there is no His-Purkinje system involved. So that gives us the confidence to diagnose as VT. A wider QRS definitely above 160 denotes more chance of VT. R by S interval I have already told. So R wave to the peak, R wave peak time more than 50 milliseconds. The V initial to V terminal in lead AVR, the ratio also gives us a clue about the ventricular tachycardia. Axis. Now a northwest axis denotes a more likely to be a VT. A left axis deviation, right bundle branch block morphology or a right axis deviation, left bundle branch morphology is more suggestive of a ventricular tachycardia. If you can get hold of a previous ECG of the patient, again we may sometimes be able to differentiate a VT from an SVT because we can see the change in the axis and the morphology of the QRS.